கொஞ்சம் ஜூம் பண்ணி காமிச்சா
அதான் அது காணும். அப்படி சொல்றீங்க. அவனுக்கு வீட்டுக்கு அது இதில் கனெக்ட் பண்ணிக்கலாம் சிபிடி பண்ணலாம். இது கனெக்ட் ஆகிடுமா?
அவ்வளோதான் மேக்ஸிமம். அவ்வளோதான் மேக்ஸிமம்.
இதில் ப்ளஸ் எங்கே இருக்கு? ப்ளஸ் டிஜிட்டலாக ஜூம் பண்ணிவார். அது நல்லா இருக்கும். அதுக்கு ஆல்ட்டு தெரியும். ஆனால் இவ்வளோ தூரம் போகுது, பின்னாடி பூரா வருது. மைனஸ்
ಲೈಟಿಂಗ್ ಪೂರ್ಣ பேசுகிறோம். பேசாமல் லோய்த்து அப்படியே சும்மா மாட்டி பாரு ஆஃப் பண்ணிட்டு ஜூமில் மாட்டி பாரு. இப்போ ஸ்டார்ட் பண்ணிட்டாங்க.
I request everyone to rise for the prayer song.
திக்கடமும் ஒரு சிறந்த திராவிடன திறனோடும் தக்க சிறு பிறனுதரும் தரிதரும் திலகமும் அத்திலக வாசனை போலனை புலகும் இன்பமுற எத்திசையும் புகழ்வன கையிருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திரும்பிழுந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
I now invite the dignitaries to light the Kudwal.
Good morning to everyone. I would like to welcome my Dr. K.SEETHA LAKSHMI, welcome all the way from MMSC for you all students. So you grab maximum knowledge about whatever I will share, and her knowledge with you, we attend you, and everybody knows that MMSC is not only famous in India but it is world famous for its academic hub. So I congratulate Department of Obstetrics and Gynecology for organizing this young meeting for all the students. All of you take maximum benefit, and I wish all the best for all of you. Thank you.
I now request Dr. LAKSHMI, Professor, Department of Obstetrics and Gynecology, to give you a welcome address.
Prof.Dr. I'm extremely happy to welcome Dr. Sulana, our Chief Guest, Dr. Professor of Obstetrics and Gynecology. We are honored to have the knowledge and experience on POP. Prolapse is an important topic both undergraduate and postgraduate. Within the topic, everybody pick up with the society, what she is for 20 years ago, those who are on the stages also. It's a very important topic in general also. Very much to go in depth about PELVIC prolapse. Yes, and actually, a couple of years ago, for example, at that time we were discussing suicide harassment and all. So she was international faculty for hands-on workshop, which are here in the United States of America. And she was listening to each other, but because of the corona, couldn't make it. I think you people are lucky. Both this is Raj and Raj and Bogan and lucky because analysis come today. Because the plan years back and better. Yes, and then last day, in the management, I looked at the elements of my easy activity. When I saw what was defined as the POP manners, the international standard, so last, the advocacy of last. Okay, some of them have 4 years, 5 years of the government. So let us ask madam to effect and ask the to society and access and the patients to know a lot talk also and demonstrate the survey also so that they feel how to detect a blood, open the PO door, also methods and conduct class, everything on the demonstration cases. According to the fully available, readily accepted, and I think you know the management because to show it to survey there, everybody take what I can go. So PGs and UGs are so state of the knowledge was already created. So thank you for that also. And thank you extremely because of our knowledge and decision. It was so that hospitals, the body as epidemiology, means the disease practitioner. In spite of that, there is such a job teacher. So please, this is Carolina, very less. Clara, because I asked very complex areas. The examples. So I'm going to college and my system.
It was a great pleasure and honor that I introduce today's guest speaker, Prof.Dr. K.SEETHA LAKSHMI. She is a certified urogynecologist and is currently working at the Institute of Obstetrics and Gynecology in Madras Medical College, Chennai. She has a special interest in pelvic prolapse, especially water prolapse and urinary incontinence. She has done extensive research in autologous patients in abdominal staging for pregnancy. She was awarded a PhD in urogynecology by Dr. MGR Medical University in December 2022. Since 2011, she has been training specialists in urogynecology and has been a reviewer at IAJ. She has 15 national and international publications to her name. She has been an active participant in various national OBG and epidemiology conferences as a faculty. She has presented several papers in countries all over the world like Austria, Portugal, etc. She is an international faculty for hands-on training workshop on POC2 in Italy and USA. She is a custody auditor of Women's Health in All India Radio Chennai. She has been interviewed by many SCTV channels and newspapers with regard to rare surgeries form. Her professional achievements aside, her hobbies is grooming pets, meditation and running. We welcome you, ma'am.
Respected Dean, respected LAKSHMI, Prof.Dr. Madam, respected Pathogenesis Assistant Professors of OBG Department, Post-Therapists, Undertherapists. I am very much delighted to talk on PELVIC PROLAPSE today. And here I love to be very academic. I love teaching. So I use such efforts to share my knowledge and experience with you. And so I really thank Dr. Madam LAKSHMI for giving this opportunity to share my knowledge with you. Without wasting much time, let me talk on PELVIC PROLAPSE and overview. The objective of this symposium is to highlight the pathophysiology, recent pathophysiology of PELVIC PROLAPSE, so that to focus on the recent guidelines regarding the diagnosis and management from various scientific evidence which is consistent with the recent guidelines. And PELVIC PROLAPSE, it is a global health problem, and because of the longevity of the female life, because of the increase in the life expectancy of the female population, there is increased incidence of PELVIC disorders globally. And so, what is the definition of PELVIC PROLAPSE? So according to the International Continence Society, the PELVIC PROLAPSE is defined as the descent of one or more of the anterior abdominal wall, posterior abdominal wall, the cervix or apex of the vagina, the hysterectomy is done. There is no word uterine prolapse. Please don't use the diagnosis of uterine prolapse. Only the uterus is not prolapsing. So always the latest classification, worldwide classification is, definition is PELVIC prolapse. Don't say third degree UV prolapse, fourth degree UV prolapse. It is outdated. So what is the degenerative level of support? It is very important. The level of support is formed by the uterosacral ligament. Here you can see uterosacral ligament and the paracardium. The uterosacral ligament and paracardium is responsible for the level of support, that is the support of the cervix and the enterocyst, prevention of enterocyst. So this is also called as the suspension axis. Delancing level of support level is called as the suspension axis. So it is suspended the uterus by very good support by the uterosacral ligament and paracardium. And the level 2 support is mid-vaginal support. It is a circular shape. Mid-vagina is a circular shape, and anteriorly the vagina is supported by the pubis cervical fascia, which is attached to the origin intended fascia, which is laterally, and posteriorly the rectum is supported by the rectovaginal fascia, which is attached to the origin intended rectalis. So the level of support is maintained by the pubis cervical fascia anteriorly and rectovaginal fascia laterally. Here you can see vesicovaginal fascia and rectovaginal septum. So when there is a defect anteriorly, this is called as systolic and when there is a segment posterior, this is called as rectosecondary. So the level 2 support is called distribution. picture you can see the distribution of incidence rate between 1990 and 2090, and the purple is the 2090, 90, and the green dot is the 1990, and this graph depicts the socio-economic, socio-demographic index ratio in various countries. The socio-demographic index ratio is more in Pakistan, Bangladesh, and Thailand. Okay. So here you can see that as age advances, the incidence increases, and there is a bipolar distribution between 3 to 4 years, and then the incidence is varying between 65 and 69, and there is a increase in incidence after 80 and 75 years. So as age increases, there is increase in incidence of pelvic organ prolapse. What is the Asian women have stronger pelvic support, and there is increased mobility and ankle and posterior vertebral than Caucasians. So the incidence of some POB is less compared to the other Asian women. Whereas in white women there is more chance of POB, there is 10.17%, and Hispanic women are prone for 6.55%. And the incidence is 3.8% compared to Asian American women, where the incidence is 3.14%. So in this graph, you can see the Hispanic women, the incidence is 5.14%, in the non-Hispanic women, where the incidence of pelvic organ prolapse is less. And according to parity, there is more incidence of pelvic organ prolapse when the women has 2 or more children. This depicts 3 and more children, and this is 2, the parity is 2 and this is 1, and this is nulliparous where the incidence is 0.6%. So coming to the body mass index, when there is an increase in body mass index, the obesity has effect on the pelvic floor ligaments and muscles. So because of the obesity, the pelvic floor ligaments becomes lax and there is more chance for pelvic organ prolapse. The increased BMI, when there is increased BMI more than 30, there is more chance of pelvic organ prolapse. So obesity has a major role in the risk factor of pelvic organ prolapse. So what is the association of urinary incontinence in pelvic organ prolapse? Pelvic organ prolapse and stress urinary incontinence coexist in up to 80% of women with pelvic floor dysfunction. The incidence of mixed urinary incontinence in pelvic organ prolapse is 34.3%. The prevalence of all urinary incontinence is 22 to 80% compared to women without pelvic organ prolapse, where only 3.9 to 64% has all urinary incontinence. So look at this figure. The isolated pelvic organ prolapse is very rare, and it is associated with more of stress urinary incontinence and the all urinary incontinence, and this is the mixed urinary incontinence. So what is the etiopathogenesis of pelvic organ prolapse? The prolapse uterus is only the result, it is not the cause. So what is the cause for that prolapse? It may be due to collagen defect and lead to levator muscle dysfunction and decreased tone. See, the levator plate normally extends from the coccyx and the pubic symphysis, and this is the normal genital hiatus, and the length of the normal genital hiatus is 4 to 5 centimeter. So when the levator plate is intact, the levator shelf maintains the position of all pelvic organs, preventing from prolapse. Whereas when there is decreased levator muscle tone or levator muscle dysfunction as a result of childbirth injury, especially the complicated traumatic vaginal delivery, when the patient strains too much, at one point of the time the muscle fibers rupture. What happens? Usually 6 weeks after parturition, the levator muscles has to regain its tone. Whereas
in complicated deliveries, instead of regaining the tone because of the rupture of the muscle fibers, the levator muscle undergoes dysfunction, decreased tone, failure of regeneration and hypertrophy. Because of that, there is a shagging of the levator plate, thereby the dental hiatus becomes patulous, and in severe cases it is very much shagging and the dental hiatus is very large, more than 8 cm, allowing all the pelvic organs to prolapse. So what is the levator ana defect? It is a very important aspect which occurs due to prolonged second stage of labor, difficulty instrumental delivery, when there is a delivery of large fecal head, and when episiotomy is not properly sutured, and unidentified anal sphincter tears, all predisposed to levator ana defect. So how will you diagnose pelvic organ prolapse? So the diagnosis is based on prolapse symptoms, bladder symptoms, bowel symptoms and sexual symptoms. So what are the bladder symptoms? Usually the patients will have voiding difficulties, and I want the students to concentrate. Many of the students are talking among themselves. Please stop talking and listen. Please don't distract me from my lecture. And so there is voiding difficulties and incomplete bladder emptying. This is the most common symptom of a pelvic organ prolapse. Most of the time the patient has to reduce the prolapse to aid voiding, to initiate and complete voiding. And recurrent urinary tract infection is common because of always there is a significant post-void residual urine, and because of this the patients will have recurrent UTI. And the prolapse symptoms, of course the patients will have a mass bulge in the vagina or outside the vagina, white discharge per vaginum, irregular bleeding per vaginum. All these are the symptoms of prolapse. So the bowel symptoms are outlet type constipation and defecated dysfunction, and sexual symptoms of course decreased libido and dyspareunia. So the normal anatomy is here, because of the levator shelf is not it is maintained in its anatomical position. The bladder, the uterus, rectum all lie in the same line, whereas in this case only the uterus is prolapsed. So the predominant defect is the level 1 defect, and the concomitant defect is the rectum and the bladder. Here in this case it is a vaginal wall prolapse after hysterectomy. This is the normal and abnormal anatomy. Coming to the classification of a pelvic organ prolapse, in 1950s Baden-Walker classification was used. In 1996 the worldwide classification is POTQ. So the POTQ classification is stage 1, 2, 3 and 4. I will demonstrate the video of POTQ. The stage 1 is inside the vagina, and stage 2 is up to the hymenal ring, stage 3 is beyond the hymenal ring, and stage 4 is the complete eversion, and the reference point is always the hymenal ring. So there are 3 points in the anterior compartment, AA, BA and C, 3 points in the posterior compartment, AP, BP and D, and the other 3 fixed points are total vaginal length, genital hiatus and perineal body. So these are the 9-point patient pelvic organ prolapse quantification, which I will come to in detail. So POTQ video, let me show you the POTQ video. video is not coming in the, I don't know what is the reason, but it is playing in the laptop. I nicely prepared and got for the postgraduates. I'm very sorry that the video is not playing. I was very prepared. I will demonstrate when I do something. That's all I can do. This is the part 2 grade. You have to mark the points AA, BA and CB upper grade and AP, BP, D the lower. Genital titles and perineal body and total vaginal length in the lower one. So in this case, the AA point is +3 and BA point is +6 and C point is -2. So all the plus points are prolapse and the negative points are minus. Okay. So AA point is +2, +3 and BA point is +6. So it is the C point is the cervix, it is minus. So this is the hymen. So this indicates only level 2A cystocele because the C point is within the hymen, So this indicates the cystocele. And this picture shows AA point is -3, BA point is -6 and C point is also minus. So all are inside the hymen and there is no prolapse of the anterior compartment. Whereas the AP point is +2 and the BP point is +5 and the total vaginal length is 8 cm. So AP point and BP point, when stage 3 is when the leading point of the prolapse is less than total vaginal length minus 2 cm. So the total vaginal length is 8 cm. So when it is less than -2 means 6. So it is called stage 3 posterior wall prolapse. Understand how to diagnose like this. So here the total vaginal length is 6 cm. So when the leading point of the prolapse is more than, less than total vaginal length minus 2 cm, then it is stage 3. When it is more than total vaginal length -2, here it is +6. So it is almost equivalent to total vaginal length -2. So this is called stage 3 cystocele. You have to calculate like this. So the simple teaching tool used for part 2 is the standard plus cap. So what I do is I take the standard plus cap and that embroidery frame I fix it as a hymen and I will fix the buttons for AA, PA and AP point and I teach the students by using this standard plus cap for demonstrating the part 2. And I was the faculty in part 2 hands-on workshop in the International Eurovena Conference in Italy, Como. And this is the hospital where I did my fellowship and he is my professor, Dr. Morris. Now I will show some differentiation between the cystocele and rectocele. So when you want to diagnose the cystocele, you put the speculum posteriorly, ask the patient to do Valsalva manual and this is called the cystocele. When you want to demonstrate rectocele, you put the 6 speculum anteriorly, ask the patient to strain and look for a bulge and there is a bulge which is called rectocele or posterior wall prolapse. And so what is the diagnostic approach? You have to inspect the prolapse completely, look for the detachment of the lateral vaginal wall from the cornicial sulcus. So the clinical examination include careful inspection of the vulva and the vagina, the excoriation of the vulva, decubitus ulcer, any discharge per vaginum and staging of the prolapse. And the positioning of the patient is normal lithotomy position and the part 2 should be done in full Valsalva maneuver. You measure the points when the prolapse is inside, then ask the patient to do full Valsalva and you first mark the points. Then measure these points from the hymen in full Valsalva, which I will demonstrate in the operative case. And then bone is stress test. When the patient has stress urinary incontinence, you reduce the prolapse, anterior vaginal wall prolapse with sponge holding, ask the patient to cough and look for the evidence of stress leak. If there is no stress leak, when you reduce the cystocele, then the patients will benefit from the surgical repair of cystocele. And you have to do the evaluation of the tone of the pelvic floor muscles, especially levator ani, rectovaginal examination, and integrity of anal sphincter. Ask the patient, you assess for the squeeze pressure and the resting pressure by doing the anal examination, which is very important. So let me show me the varieties of various POP, and this is the stage 4 pelvic organ prolapse. And this is also stage 4 with the total eventration of the vagina. And you can see the vaginal, anterior vaginal wall cyst. So this is the stage 3 POP with anterior vaginal wall cyst, the tag as a result of delivery, following a delivery. And so this is a complete process. So you can see how the patients are coming with a huge prolapse up to the knee with a decubitus ulcer, and everybody knows about the cause of the decubitus ulcer and the keratinization of the vagina. And this is the stage 3 POP, and this is the wall prolapse. You can see the vagina remnant on both the ends. So the part of the prolapse above the vaginal wall is the cystocele, and this may be intrusive or ectocele, which will be confirmed by doing the rectal examination under anesthesia. So what are the special investigations you are supposed to do for pelvic organ prolapse? Apart from the routine investigations, ultrasound KUB and pelvis with the pre and post void is very important. Kidney ureter bladder is done to rule out the hydroureteronephrosis, because in pelvic organ prolapse there is a ureteral kinking, and so that leads to back pressure in the ureter and leads to hydroureteronephrosis. And pre-void and post-void is a must, because we want to know whether the patient has a existing preoperative voiding problem due to the prolapse or due to the external urethral, distal urethral stenosis. So any patients who have a significant post-void residual urine, that is more than 1/3 of the pre-void, is called a significant post-void residual urine. And cystourethroskopy is indicated when you suspect bladder outlet obstruction like distal urethral stenosis, when there is a multiple bladder calculi on ultrasound, and when the prolapse is irreducible. So the causes of irreducible prolapse may be due to multiple bladder stone or prolapse associated with the fibroid uterus, and the commonest cause is severe congestion and edema, and another cause is fibroid uterus and ovarian tumors. And the urodynamic evaluation is needed when the POP is associated with mixed urinary incontinence. Coming to the management of the pelvic organ prolapse, we have two types of management: conservative management and surgical management. Conservative management is needed when the patients are young, those who want to preserve the menstrual function, those who want to preserve the family childbearing capacity. In such cases, we go for conservative management, which include weight loss in overweight and obese women, and vaginal pessary is the second choice, and the third choice is the pelvic floor muscle training, that is called Kegel exercise. So the pessaries are known for more than 200 years. 123 type of pessaries have been registered with American Medical Association. They are all getting of decreasing importance because of the pelvic reconstructive surgery. But still it is widely used in many countries like Thailand, Malaysia, where the patient's preference for pessary is more. So what is the mechanism of action of pessary? Once the pessary is introduced, the pessary rests all the pelvic floor muscles, which is the levator ani and the components of levator ani, which you all know, that is the pubococcygeus, iliococcygeus and coccygeus. So this is the pubococcygeus, and this is the iliococcygeus, and this is the coccygeus muscle. So the pessary rests on the pelvic floor muscle, and you have to choose the correct pessary. There are two types of pessaries, space filling pessary and ring pessary, and commonly we use the ring pessaries are used. So the ring pessary is inserted after applying the estrogen cream by measuring the anterior posterior diameter and oblique diameter. Correct the choice of the and the pessary is introduced. So you have to insert either by the patient or by the physician, and if you don't remove the pessary, many patients will come to the tertiary center with forgotten pessaries, and the forgotten pessaries will lead to the carcinoma of the vagina. So the anterior vaginal wall or posterior vaginal wall. So the removal and insertion should be careful, and the patient should be under continuous follow-up once in 3 months for change of the pessary. So now coming to the reconstructive surgery for pessary. So what is the aim of the reconstructive surgery for pelvic organ prolapse? To restore the anatomy, to relieve the symptoms, pelvic visceral symptom, and to restore the sexual function. So when should we do surgery, and which surgery should be done, and how should we do? A simple surgery cannot be done for all pelvic organ prolapse patients. So always listen to the patient, and when should we operate? When the prolapse is symptomatic. Don't go and do operation for asymptomatic stage 2 pelvic organ prolapse. And when the patient has difficulty in day-to-day activities like severe prolapse can make her difficult in ambulation. Ambulation will be difficult. When she has a difficulty in voiding urine and motion, and when there is a decreased sexual function. When the quality of life is affected by these symptoms due to the pelvic organ prolapse, then you assess the staging of the pelvic organ prolapse and operate. So which operation for which case? When there is a cystocele, don't remove the uterus, do hysterectomy. When there is a cystocele, you do repair only the anterior colporrhaphy. When there is a rectocele, you do only the posterior repair and not the vaginal hysterectomy. Only when there is a uterine prolapse, as I have already told you, the prolapse uterus is the result and it is not the cause of the pelvic organ prolapse. So it is not enough if you correct the result of the pelvic floor dysfunction. So simply doing hysterectomy will not relieve the patient's symptoms, and the patients will again come to you with recurrence. So what you have to do? So what is the cause for uterine prolapse? That is due to the you have to do the apical suspension procedures. So for vaginal wall prolapse also we have lot of operations which I will tell in later. So what are the apical suspension procedures? We have reconstructive procedures and obliterative procedures. The reconstructive procedures which are commonly done are McCall's scaldoplasty, high uterosacral ligament suspension, iliococcygeus fixation, vaginal sacrospinous fixation, and abdominal sacrocolpopexy. So what is anterior repair? This is anterior repair is done for cystocele. So this is some pictures showing the separation of the anterior vaginal epithelium from the underlying pubocervical fascia, and the sutures were taken from the pubocervical fascia. So the midline plication of the pubocervical fascia after restoring the trapezoid attachment of the bladder will help correcting the anterior repair. And now coming to the posterior repair, the posterior vaginal epithelium is separated from the underlying rectovaginal epithelium, and the rectovaginal septum is repaired by midline plication of the rectovaginal fascia along with the rectovaginal septum mobilized from the perineal body. So this is the perineoplasty, which is approximation of the superficial transverse perineum and bulbospongiosus to create the perineal body. So these are some steps of vaginal hysterectomy, and you can see always the plane should be correct. If you go in a correct plane, the chances of bleeding is very less as in this case. So coming to the vaginal sacrospinous fixation, and here this is the sacrospinous ligament. The sacrospinous ligament extends from the, can you see, this is the sacrum and this is the ischial spine. So it is the fan-shaped ligament which is 4 to 6 centimeter length, and the thickness is 2 to 4 millimeter, And so the valve is fixed 2 cm medial to the ischial spine. So this is the site where the valve is anchored. Why 2 cm medial to the ischial spine? Because the pudendal vessels lie just posterior to the ischial spine. And this is the uterosacral ligament where the uterus is fixed to the sacrum by the uterosacral ligament. So the uterosacral ligament, we take stitches high in the uterosacral ligament because of the close relationship of the ureter and the uterosacral ligament caudally. So you should take stitches high in the uterosacral ligament above the ischial spine to prevent the ureteric injury. So this is the picture showing the sacrospinous ligament. So the pararectal space is entered and the sacrospinous ligament is identified. And this is the after the hysterectomy and before sacrospinous. So after the hysterectomy, still you can see all the valve is lying outside the introitus. So the sacrospinous stitches has been exteriorized through the neo apex of the vagina, then fixed to the this is the bilateral sacrospinous fixation, but usually unilateral sacrospinous fixation is enough. And this is the picture after showing the fixation of the vaginal valve to the sacrospinous ligament. So coming to the high uterosacral ligament suspension, here the vaginal valve is suspended to its original hollow of the sacrum, and that is the level 1 support, and it maintains the anatomic vaginal axis. Whereas in sacrospinous fixation, the vaginal axis is deviated to the right. So the anterior compartment is more prone for increased intra-abdominal pressure. So there is more chance of anterior compartment relapse like cystocele. Whereas in high uterosacral ligament suspension, because the anterior vaginal wall and the posterior vaginal wall are approximated by approximation of the pubocervical fascia and rectovaginal fascia with high uterosacral ligament stitches, the anatomical axis is maintained almost to the normal axis of the vagina. So this is the picture which shows the after the before surgery and after surgery, and here you can see the stage 3, and this is the picture showing the vaginal hysterectomy with McCall's vulvoplasty. So you can see the normal genital hiatus, length is maintained, the perineal body length is maintained. So it is always important to maintain the anatomy. So this is the patient of 94 years old patients referred from PELVIC Medical College to our institute with stage 3 POP, and her comorbidity is chronic obstructive pulmonary disease. So everybody is scared of doing and they have inserted pessary for so many years, and because of the elongation of the anterior vaginal wall, the pessary fell down. I did vaginal hysterectomy with McCall's vulvoplasty, and the patient is walking with support on 3rd postoperative day. So you have to assess the anatomical defect, have a good backup for anesthesia for comorbidities, and do the reconstructive surgery as better as possible to enhance the quality of the life of the patient. So this is the preoperative picture, and this is the post-op picture following the high uterosacral ligament suspension. See, you can see the normal genital hiatus and the normal perineal body. And this is the ileococcygeal fixation, and this is the immediate post-operative picture, and this is the huge stage 4 POP. So I did abdominal sacral colpopexy after hysterectomy, and this is the post-op picture, and this is uterus with hypertrophic cervix, and this is the vaginal sacrospinous fixation and McCall's vulvoplasty. And this patient has only stage 4 enterocele, where I did high uterosacral ligament suspension, and this is a nulliparous patient, and this is the immediate post-operative picture after the high uterosacral ligament fixation. So the obliterative procedure includes colpoclysis, and colpoclysis is done in patients with comorbidities where the patients cannot undergo the extensive pelvic reconstructive surgery. The colpoclysis is done. And so this is the preoperative picture and post-op picture for colpoclysis. So how will you prevent the pelvic organ prolapse? Before that, I want to go through the videos of fixations. Sorry, the part 2 video is not playing here. The Shamir says I finish the PPT and then play the video, otherwise there will be a problem. So let me complete the PPT. So prevention of BOP, how will you prevent? By doing the pelvic floor muscle training. So the pelvic floor muscle training should be started. The recent guidelines says it should start from adolescent age group like 14 years. So when we are going to school health education, we are educating the school children to do the pelvic floor exercise starting from 14 years. Once the defect occurs, if you do pelvic floor exercise, it is of not much of value. So always you should educate your family, your friends and patients to start doing the pelvic floor exercise starting from adolescent. Better to use the Indian toilet, at least weekly thrice. So the squatting position will enhance the tone of the pelvic floor muscles. And local estrogen treatment is very important for prevention of further prolapse in increasing age and hypoestrogenic patient, and reduction of straining and intra-abdominal pressure. Weight loss is mandatory with the diet and bariatric surgery, and always the second stage of labor should be supervised, and apical suspension procedures should be done along with hysterectomy, and hysterectomy alone is not enough for pelvic organ prolapse. So my conclusion is you should make the operation fit the patient. You should make the operation fit the patient, not the patient to fit your operation. So the surgeon should go to the operation theatre with the spectrum of operative procedures, so that if one should not, the procedure does not fit into the patient, immediately she or he can switch over to other patients. So what is the take home message? The normal anatomy should be maintained, the normal vaginal length should be maintained, and the vaginal direction should be maintained after your pelvic reconstructive procedures. So you should correct all the anatomic defects supporting the pelvic support. It is very important. After hysterectomy you assess, correct the level 2A defect, level 2P defect, level 3P defect. So always all anatomic defect affecting the pelvic support should be addressed. And the pericervical ring after hysterectomy is a must. So you should form the pericervical ring by approximation of the pubocervical fascia anteriorly, the uterosacral ligament posteriorly, and the cardinal ligament laterally. So the formation of the pericervical ring after hysterectomy is a must to prevent the future wall to prolapse. So apical support is the cornerstone of pelvic reconstructive surgery. So after hysterectomy, the patient should have any apical suspension procedures like McCall's scalpoplasty, vaginal sacrospinous fixation, high uterosacral ligament fixation, depending upon the level of the defect. And concomitant anterior and posterior repair along with the hysterectomy is mandatory to prevent the wall to prolapse and enterocele. So always listen to the patient with utmost care. Know your anatomy is very important. Know your surgery, and there is no restriction of movements after pelvic floor reconstructive surgery irrespective of the age. Now let me go to the videos. asking me to wait for 2 minutes.
Videos.
Nisha,
The videos in the photo. Huh? இருங்க
பிக்சரை கூட நான் அப்படியே எடுத்துடுறேன். ஃபீல் பண்ணுங்க. தெரியுதா?
Yes, ma'am. Yes, ma'am.
Yes, please.
Scale spine வந்து எவ்வளோ?
1 centimeter அல்லது just above the scale spine. இந்த பாரு ப்ரீத்தி தெரியுதா? அந்த பாரு ப்ரீத்தி radius. That's it. இனிமேல் யார் ப்ரெஷர் பண்ணுறீங்களோ அவங்க தான் வீடியோ எடுக்க மாட்டேன்னா ப்ரீத்தி அவ்வளோதான். ரிலாக்ஸ் பண்ணிக்கோ ப்ரீத்தி.
Yes, ma'am.
இப்படிவா இருக்கணும். ப்ளீஸ் யூ பி
that has not been included. After that only I will treat, only after seeing the everything complex. Now the pelvic floor repair is completed by doing the perineoplasty, and this is the post-operative picture. Shami,
This is a case of
difficult to take picture through operation and edit. So all a lot of difficulty has been done only for teaching purpose. Mesh sacrocolpopexy where the wall is fixed to the anterior sacral ligament of the anterior sacral ligament or anterior longitudinal ligament of the sacrum. Play button. Mesh sacrocolpopexy. Play button.
கொஞ்சம் லேக் இருக்கு மேம். இப்போ கால்போக்லிசிஸ் தான் ப்ளே
Play
ஆகுது.
button. The rectangular insertion was made in the anterior vaginal wall. This is the obliterative procedure where the vaginal wall is obliterated. So it should be done only in the elderly patients who does not desire the future sexual activity and those who do not withstand the extensive pelvic reconstructive surgery or the candidates for colpopexis. And the rectangular insertion was also made in the posterior vaginal wall. So after saline adrenaline infiltration, the vaginal epithelium was removed, which has been marked, was removed. And when you separate the vaginal epithelium, it is very important to leave behind the pubocervical fissure more on the bladder than on the vaginal wall. Because we are going to approximate only the pubocervical fascia and the rectovaginal fascia. See, you can see I am leaving much behind the pubocervical fascia on the bladder, not on the vaginal wall. Can you see? And similarly, the rectangular shaped vagina is removed in the posterior vaginal wall, leaving behind much of the rectovaginal fascia on the rectum than on the vaginal wall. Here, since the cervix is there, after excluding the endometrial pathology, the lateral channels are left behind to rule out the malignancy in future. So the channels are created on both the sides. Now the pubocervical fascia and the rectovaginal fascia has been approximated. The multiple rows of either bursting sutures or the transverse sutures have been used to reduce the prolapse. Thereby, the wall is elevated or the cervix is elevated by approximation of the pubocervical fascia and rectovaginal fascia, which will heal by fibrosis in future. Thereby, the wall is elevated. And colpopexis should always be combined with aggressive perineorrhaphy. Otherwise, it is a waste. See, I am checking the tunnels by using the right tube. So the tunnels are lateral tunnels are patent. The suture material used is the 20 by 3. So any doubt you can ask me. By multiple transfers to sutures, the collapse is reduced. This also means check cystoscopy to rule out the ureteric injury. Labs has been gradually. Okay. Ortholysis is also a good operation for elderly patients who have multiple comorbidities. See, now the whole collapse has been reduced. Multiple rows of features approximating the 2% people and the 2%. Now the wall has been closed. And it is very important to maintain the hemostasis when you do the colpoplasis. Otherwise, post-operatively, the patients will develop hematoma, infection, wound breakdown. So, meticulous hemostasis is very important. Can you see? I am pulling and checking the facial support. It is strong. I have not taken the seals of the bladder or rectum because I have taken this fascia. When I pull and check, it is strong support. Only the facial support has to be maintained by taking the cervical fascia and rectovaginal fascia, and not the seals of the bladder and rectum. Can you fast forward? Little bit. Now the wall is closed. Can you fast forward?
Flag letter కొంచెం.
This is followed by the aggressive perineorrhaphy, which form the levator shelf, whereby the pelvic organs will rest. So, aggressive perineorrhaphy should be done whenever colpoplasis is done. Now, the patency is checked. The patency of the lateral canal has been checked by introducing the two aortic flap. Now, everything has gone inside. Next week, I am not showing the perineorrhaphy, which you have already seen. Mesh is taken colpoplasis. This is the post-operative picture of colpoplasis. Okay. Next week.
and a self-retaining retractor to have a good exposure of the pelvic cavity. Now the ureter on the right side is identified by inspection and palpation, and after lateralization of the right ureter, the posterior peritoneum was opened between the right ureter and the sigmoid colon on the left, and the incision was started from the top of S1 up to the pouch of Douglas. Now the anterior sacral ligament was identified by clearing the loose endopelvic fascia over the sacral promontory, that is at the level of S1 and S2. 3 sutures were taken with 1,0 proline at the level of S1 and S2 in the anterior sacral ligament, and all these stitches were tagged. And care should be taken to avoid injury to the middle sacral artery and vessels. Now the PROLAPSE mesh was designed into Y-shaped to have a anterior and posterior arm with Y-shaped mesh with the sacral end of 3 cm and the vaginal end should be 6 cm. After designing the Y-shaped mesh, the vaginal stent was kept and the rectovaginal space and vesicovaginal space was created by a sharp dissection started transversely in the UV fold of peritoneum anteriorly and the pouch of Douglas peritoneum posteriorly on either side. After creating the vesicovaginal space and the rectovaginal space creation, the mesh was kept. And in this place, the bladder dissection should be careful to avoid injury to the right ureter. Now the mesh was placed. First, the posterior arm of the mesh was placed over the rectovaginal septum using 20 PDS, and multiple stitches were taken in multiple rows, usually 3 rows, and each rows contain 3 stitches with the 20 PDS. And it should not include the vaginal epithelium both anteriorly and the posteriorly, and only the vaginal fibromuscularis should be taken when the stitch is taken over the mesh along with the vesicovaginal septum and the rectovaginal septum. Now, after keeping the mesh graft over the posterior vaginal wall, the fixation of the graft over the anterior vaginal wall is started, and the distal sutures are taken with the 20 PDS in 3 to 4 rows, and each rows contain 3 stitches of the PDS. And here also the care was taken not to include the vaginal epithelium, and the graft should be attached only to the vaginal fibromuscularis along with the pubocervical fascia. After attaching the mesh on both the sides, in the midline, in the distal part, the graft is attached to the lateral side, which is very important. And the care should be taken that the graft should lie flat on the posterior and anterior vagina for a distance of 4 to 5 cm so that the good security is attached to the vaginal vault. Now the apex of the mesh is attached to the apex of the vaginal vault. Now extraperitonealization of the mesh was done by taking a stitch on the medial side of the pararectal incision, and then the posterior edge of the cul-de-sac peritoneum, the caudal edge of the mesh, then left lateral side of the mesh, and the zeros of the UV fold of the peritoneum, followed by the right side of the mesh and the right side of the pararectal incision. And this extraperitoneal stitch should also include the anterior wall of the rectum. So this pursing stitch is closed, which maintains the extraperitonealization of the mesh, which is important to prevent the small bowel obstruction. After extraperitonealization of the mesh, the vagina is pushed towards the hollow of the sacrum and the mesh is inserted to the anterior sacral ligament with the stitches already taken on the sacral ligament. Care should be taken. There should not be any tension over the mesh between the vaginal vault and the sacral ligament. After securing the mesh over the sacral ligament, the caudal stitches are tied first, followed by the cranial stitches. There should not be any shrinkage of the mesh on tying of the mesh over the sacral ligament. Now the posterior peritoneum over the mesh was closed. So this is the closure of the peritoneum after the mesh fixation. Now the perineoplasty was done to narrow the genital hiatus, which was patulous to more than 5 cm. So perineoplasty was done by approximation of the bulbospongiosis and superficial transverse perineum to narrow the genital hiatus up to 4 cm, which is very important. Even though mesh sacrocolpopexy was done abdominally, the perineal defect should also be corrected to maintain the normal anatomical length of the perineal body and the genital hiatus.
Though the mesh sacrocolpopexy is done, we should assess the perineal body from below and do the necessary corrective.
So this is the immediate plasty, and the vagina is well supported and the axis is more towards the normal axis in the hollow of the sacrum.
These are all the variety of procedures done for pelvic organ prolapse. I will demonstrate the sacrospinous fixation in the case, so I am not showing the video. Now you can see this is the immediate post-operative picture. Thank you very much. If you have any doubt, I am welcome to answer your questions.
I request Dr. Tilber Sundari ma'am, Assistant Professor from Department of Obstetrics and Gynecology, to deliver the vote of thanks.
On behalf of the Department of Obstetrics and Gynecology, I am honored to deliver the vote of thanks. I thank our guest speaker, Prof.Dr. K.SEETHA ma'am, who, despite her busy schedule, has come here to grace the event and enlighten us with her words of wisdom. Thank you, ma'am. I thank our Managing Director, Medical Director, Medical Superintendent, and Principal ma'am for the valuable support. I thank our Professor, Dr. LAKSHMI ma'am, for her efforts for organizing this event, great planning and precision. Thank you, ma'am. I extend my sincere thanks to Dr. Murli Manoj sir, Associate Professor, Department of Anesthesia, Mr. George from Audiovisual Department, Mr. Shantakumar and his team, and Ramaswamy sir and the technicians of this CME hall. Finally, I thank all our staff and students for their active participation in making this event a grand success. I thank the pharma company for their sponsorship. Thank you.
older சொல்லிட்டு போனாங்க